Picture an ordinary Tuesday morning. Coffee on the counter, sunlight cutting through the blinds, a 71-year-old man lacing up the same walking shoes he has laced up for over a decade. He is not tired, he is not dizzy, he has not felt a single strange flutter in his chest in years. And yet, 3 weeks from this completely ordinary morning, he will be lying on an operating table while a surgeon opens the side of his neck to remove a piece of an artery he did not even know he had a problem with until a few weeks earlier. Nothing about his body changed in those 3 weeks. What changed was a single piece of paper stamped with one quiet, reassuring word: routine. If you are over 65 and you feel completely fine, that word deserves a much closer look than most of us ever give it. There is an assumption almost all of us carry into a doctor's office without ever questioning it. We assume more testing automatically means more safety. We assume that catching something early is always better than never looking for it at all. For a long list of conditions, that assumption holds up beautifully and screening genuinely saves lives. But there is one specific corner of cardiology, the medicine of the heart and its vessels, where that assumption quietly starts to break down, and almost nobody explains this to patients before they sign a consent form. This is the story of what happens when a perfectly healthy heart gets screened anyway, why the numbers on the page do not always mean what they appear to mean, and why some of the most respected medical research panels in the country have started telling doctors to slow down before testing people who feel completely well. Let's go back to that man for a moment, because his story is far more common than most people realize, and understanding exactly how it unfolded is the key to protecting yourself or someone you love from the same chain of events. He went in for what his clinic called a wellness visit, nothing urgent, just a baseline check before the holidays. Somewhere inside that appointment, a nurse pressed a small ultrasound probe against the side of his neck to check blood flow through his carotid arteries, the 2 major vessels that carry blood up toward the brain. It took perhaps 15 minutes. He never specifically requested it. He simply did not say no, because why would anyone say no to a free, painless look at their own arteries? The image showed a narrowing, not a dramatic one. A modest buildup of plaque, the kind that exists quietly inside the arteries of an enormous percentage of people his age. But once that narrowing appeared on a screen, it could not be unseen, and the machinery of modern medicine, built almost entirely around the instinct to act on visible abnormalities, quietly started turning. This is where we need to talk about something most patients never get a clear explanation of, and it sits at the center of almost everything in this video: the difference between a body that is simply aging and a body that is genuinely diseased. Those two things can look remarkably similar on a scan, and untangling them is one of the hardest judgment calls in all of cardiology, even for experienced physicians. Here is the underlying biology, explained as simply as possible. Every blood vessel and every chamber of your heart undergoes a slow architectural renovation across the decades. Collagen fibers stiffen the way an old garden hose stiffens after years in the sun. Calcium quietly deposits itself along artery walls, similar to the mineral scale that builds up inside a pipe that has carried water for 40 years. The heart's internal electrical wiring, the same wiring an EKG reads, develops small quirks and variations simply from decades of continuous use, somewhere around 3 billion heartbeats by the time a person reaches their 70s. None of this is automatically disease. Much of it is simply what a heart that has been beating for 7 or 8 decades looks like from the inside. A 25-year-old cardiovascular system and a 75-year-old cardiovascular system are not the same machine running at 2 different speeds. They are genuinely different machines, shaped by different amounts of time, stress, and biological wear. The complication is that most diagnostic tools were never built with that distinction fully in mind. A scanner does not know your age. It only reports what it detects, and what it detects in an aging heart can resemble early disease even when no disease is actually present. That single overlap, where normal aging and early disease can look almost identical to a machine, is the hidden root of a striking number of unnecessary cardiac procedures performed on healthy older adults every year. Once you understand that root cause, the rest of this story starts to make a very different kind of sense. So why does the healthcare system keep testing people who feel completely fine if the risk of doing so is real? The honest answer involves both medicine and human psychology, and it is worth sitting with for a moment rather than rushing past. Physicians are trained, quite reasonably, to act on what they find. If a test reveals something flagged as abnormal, a doctor faces genuine professional and even legal pressure to investigate it further rather than dismiss it. even when that abnormality might never have caused a single symptom across the rest of that person's natural lifespan. Researchers who study this exact pattern use a specific term for it: overdiagnosis, the detection of a condition that technically exists but would likely never have caused harm, pain, or death if it had simply gone unnoticed. Overdiagnosis is not the same thing as a wrong diagnosis. The plaque really is there. The unusual heartbeat pattern genuinely shows up on the printout. The test did not lie to anyone. The deeper problem is that biology is messier than a single number on a page, and not every real finding deserves a real intervention. Layer onto this the simple psychology of being a patient in that chair. When a doctor says the word abnormal out loud, very few people respond with calm curiosity. Most people respond with fear, and fear is an extraordinarily powerful motivator toward action, almost any action, even when the statistically wiser choice would be patience. Behavioral researchers sometimes call this action bias, the deeply human instinct that doing something, anything, feels safer than doing nothing, even when the evidence quietly points the other way. A surgeon offering to fix a narrowed vessel feels like protection. A doctor calmly suggesting, let's just keep an eye on this, can feel emotionally like being left exposed, even when watchful monitoring happens to be the medically smarter path forward. Recognizing this bias in yourself before your next appointment is one of the most protective things you can do for your own long-term health. Now let's walk through exactly where this plays out in real clinics, screening by screening, starting with a test almost everyone over 50 has had at least once without giving it a second thought: the resting electrocardiogram, far better known by its short name, the EKG. An EKG measures the electrical signal that tells your heart muscle precisely when to contract. A handful of small, sticky sensors on your chest, arms, and legs, a few minutes of lying perfectly still, and a printed strip or digital readout showing the rhythm of your heartbeat. It is one of the most common, least invasive tools in modern medicine, and for someone experiencing chest pain, palpitations, or an unexplained fainting spell, it remains an essential and genuinely life-saving piece of equipment. The concern researchers have raised is narrower and more specific than people often assume. It is about using this tool as a routine screening test on people who feel entirely well and carry no significant elevated risk for heart disease. The United States Preventive Services Task Force, an independent panel of physicians and scientists whose entire purpose is evaluating the actual evidence behind preventive medicine, has reviewed this precise question in detail. Their conclusion was that for adults at low risk of cardiovascular disease who show no symptoms whatsoever, routine resting or exercise-based EKG screening does not meaningfully improve health outcomes, and in fact may cause net harm through a chain reaction of unnecessary follow-up testing. The reasoning rests on something called the false positive rate. In any population of healthy people, a screening tool that flags abnormal-looking results will inevitably flag some hearts that are not diseased at all, simply variant, simply aging, simply unique to that individual. The lower the actual underlying rate of disease in the group being screened, the higher the proportion of flagged results that turn out to be nothing more than false alarms. Test 1,000 low-risk, symptom-free older adults, and you will reliably generate a meaningful number of confusing or borderline readings that lead nowhere useful except more testing, more anxiety, and occasionally, more invasive procedures that were never actually warranted in the first place. There is a deeper layer of cardiac biology worth knowing here, because it explains exactly why this happens so often in older adults specifically. As the heart's conduction system ages, small and largely benign electrical quirks become extremely common: a slightly delayed signal between the heart's upper and lower chambers, an occasional early extra beat, a minor variation in how the electrical wave travels through aging tissue. To a screening machine designed to flag anything outside a textbook perfect pattern, these everyday signs of an aging heart can look indistinguishable from something far more concerning. A trained cardiologist reviewing the full clinical picture often recognizes these patterns as harmless. A routine screening pathway, moving quickly through dozens of patients a day, does not always have that luxury of context. And this is precisely where the deeper risk hides. A flagged EKG almost never ends with the EKG itself. It typically leads to something carrying real measurable physical risk: a coronary angiogram. This procedure involves threading a thin catheter through an artery in the wrist or groin, guiding it up toward the heart, and injecting a contrast dye so the coronary arteries become visible on a live X-ray. It is an extraordinary piece of medical technology, and for the right patient in the right clinical situation it can be genuinely life-saving. But it is not without risk: bleeding at the catheter site, damage to the artery wall, a reaction to the contrast dye affecting the kidneys, and in rare instances, a stroke or heart attack triggered by the procedure itself. None of these outcomes are common, but they are real, and they sit on an entirely different risk tier than a painless 10-minute EKG. A person who walked into a clinic with zero symptoms can, through this exact pathway, end up exposed to risks they never needed to face, all because a screening tool interpreted a normal variation as something requiring urgent further investigation. This single pathway is worth pausing on because it illustrates something true across almost the entire rest of this story. The danger rarely lives inside the first test. It lives in everything that first test quietly sets into motion. Now consider a test many active, health-conscious seniors specifically request because it feels proactive and responsible: the exercise stress test, often described simply as a treadmill test. Here you walk on a treadmill while the speed and incline gradually increase, wired the entire time to a heart monitor that tracks your rhythm and blood flow response under genuine physical exertion. For someone who already experiences chest discomfort during activity, this test is an important diagnostic tool, helping a physician understand whether reduced blood flow is actually occurring under physical stress. But for someone with zero symptoms, someone who can climb 2 flights of stairs without the faintest hint of breathlessness, the entire picture changes considerably. Clinical guidelines published jointly by the American Heart Association and the American College of Cardiology specifically caution against using exercise stress testing as a general screening tool for people without symptoms. The reasoning echoes exactly what we just covered with the EKG. Apply any diagnostic test to a population with a genuinely low rate of underlying disease, and a significant share of the positive results will be false positives, abnormalities that do not actually reflect a meaningful blockage. A positive stress test almost always sets off the same downstream sequence: a referral for cardiac catheterization, the same wire-end camera procedure described a moment ago, this time specifically searching for narrowed coronary arteries. This is where one of the more important pieces of cardiology research from the last 2 decades becomes essential to understand. A large, carefully designed clinical trial known as the ischemia trial enrolled several thousand patients living with stable coronary artery disease, meaning narrowed arteries that were not causing any emergency symptoms, and divided them into 2 groups. One group received an invasive strategy, catheterization, and, where appropriate, stenting to open the narrowed vessels, layered on top of medication. The other group received medication and lifestyle management alone without the invasive procedure unless their symptoms later worsened. After years of careful follow-up, researchers found that for these stable patients, the invasive approach did not meaningfully reduce the risk of future heart attacks or extend overall survival compared with medication and lifestyle changes by themselves. The procedure did, for patients who already had chest pain, noticeably improve quality of life and reduce angina symptoms, a benefit that genuinely matters and should never be dismissed. But for someone with no symptoms at all, identified only because a screening test went looking for trouble, that quality of life benefit simply does not apply because there was no symptom present to relieve in the first place. You absorb the procedural risk. You receive none of the corresponding benefit. That asymmetry, all risk and no benefit, is exactly what researchers worry about when stress testing drifts outside its intended clinical use. There is a fascinating piece of vascular biology that helps explain why this finding is not as strange as it first sounds. Doctors used to assume that the size of a blockage was the main thing that determined whether someone would have a heart attack, so naturally the thinking went, fixing the biggest blockages should prevent the most heart attacks. Decades of further research complicated that picture considerably. Many heart attacks turn out to be triggered not by the largest, most visibly narrowed arteries, but by smaller, less obstructive deposits of plaque that become unstable and rupture suddenly, almost without warning, even when they were never large enough to be flagged as dangerous on an earlier scan. This is sometimes referred to as vulnerable plaque. A stent placed inside one large, stable, visible narrowing does very little to protect against a completely different, smaller deposit elsewhere in the arterial system suddenly destabilizing. This biological nuance is a major reason why mechanically widening one visible blockage in a person without symptoms so often fails to translate into the dramatic, life-extending benefit that intuition suggests it should. There is also a psychological aftermath worth nomming honestly because it never appears on a hospital bill, yet it is one of the most consistently reported harms in this entire area of research. People describe becoming hyperaware of every small twinge in their chest after hearing that something was found. They cancel travel plans. They stop hiking, stop gardening, stop the exact activities that keep an aging cardiovascular system genuinely resilient, all triggered by a number on a printout that introduced a level of fear which simply did not exist the day before the test. Researchers sometimes call this the labeling effect, the well-documented tendency for a diagnostic label, even an accurate one describing a low-risk finding, to permanently change how a person experiences their own body and their own remaining years. Now to a screening that has become something of a fixture at community health fairs, senior centers, and pharmacy parking lots across the country. The carotid artery ultrasound, frequently advertised as a simple stroke risk check. A technician runs an ultrasound probe along the side of your neck for 10 or 15 minutes, painless and non-invasive, examining blood flow through the two main arteries that supply the brain. It often costs very little, sometimes nothing at all, and it is marketed, understandably, as exactly the kind of responsible thing a health-conscious older adult should do for themselves. The complication is that the very same task force that reviewed routine EKG screening also reviewed this exact test and reached an equally clear conclusion. For people who have never experienced a stroke, a transient ischemic attack, or any neurological warning sign, screening the general population for carotid artery narrowing is, on balance, more likely to cause harm than to prevent it. The reasoning circles back once again to what happens after a positive finding. The surgical procedure used to clear a narrowed carotid artery is called a carotid endarterectomy, in which a surgeon opens the side of the neck and physically removes the plaque buildup from inside the artery wall. For someone who has already experienced stroke-like symptoms, this surgery can meaningfully reduce the risk of a future, more serious stroke, and the research supporting its use in that specific population is genuinely strong. But for someone who never had any symptoms to begin with, the calculation flips noticeably. The surgery itself carries a real, measurable risk of causing a stroke during the operation, the exact outcome it was meant to prevent in the first place. Multiple analyses cited by the task force found that in people without symptoms, the surgical risk frequently outweighs the modest, theoretical long-term benefit of clearing and narrowing that, statistically, might have sat quietly in that artery for the rest of that person's natural life without ever causing a single problem. It is worth understanding, gently and without cynicism, that many of these community screening events are organized by businesses whose financial model depends partly on generating referrals for follow-up imaging and procedures. That detail alone does not make the ultrasound technology dishonest, and it certainly does not mean the technicians running it have any bad intent. But it does mean the setting is not entirely neutral in the way a routine, unhurried visit with your own established physician tends to be, and it is a reasonable detail to keep in mind before agreeing to any screening offered in a parking lot rather than a clinic. Think about a retired schoolteacher in her early 70s, the kind of woman who still walks 4 miles most mornings and tends a garden until her hands genuinely ache from the work. She visits a free vascular screening van parked outside her pharmacy because a flyer promised peace of mind before her grandchildren's visit. The scan finds a moderate narrowing in one carotid artery. She is referred to a vascular surgeon, who recommends surgery within the month. She does what more people in her position should consider doing, and quietly seeks a second opinion from an independent cardiologist with no financial stake in whether she ultimately has the operation. That second physician reviews the very same images and reaches a different conclusion. Given her complete lack of symptoms, the wiser path is closer monitoring, blood pressure and cholesterol management, and a repeat scan in roughly a year, not an immediate operation. She never has the surgery. Years later, she still has not needed it. The screening van did not save her from a stroke, it very nearly walked her straight into one. None of this is meant to frighten anyone away from genuine medical care, and it is worth saying plainly before moving any further. If you experience chest pain, pressure, or tightness, especially if it spreads toward your arm, jaw, or back, if you experience sudden shortness of breath, unexplained dizziness, fainting, or a racing or irregular heartbeat that feels new or different, these are symptoms, and symptoms change the entire equation immediately. Prompt evaluation in that situation is the right and responsible choice every single time. There is one more test worth understanding closely, partly because it has grown rapidly in popularity among health-conscious adults over 50 in recent years. The coronary artery calcium scan, often shortened to a CAC score, performed using a specialized CT scanner that detects calcium deposits along the walls of the heart's own arteries. In the right context, this is a genuinely valuable clinical tool. It was developed and validated primarily for adults in their 40s and 50s who fall into a borderline risk category, people whose doctors are actively weighing whether to start a cholesterol-lowering medication. In that specific population, a calcium score of 0 can be meaningfully reassuring, and a high score can genuinely shift a treatment decision in a useful direction. The tool does precisely what it was originally designed to do. The complication once again comes down to age. By the time most people reach their late 60s, 70s, and 80s, some degree of arterial calcium buildup is close to universal. It is not by itself a sign that something has gone wrong. It functions more like a biological signature of having lived a long life, not unlike gray hair or skin that has gradually lost some of its elasticity over the decades. The scan, however, has no built-in way to communicate that nuance through a single number. It simply reports a score, and in an older adult, that score can climb into the hundreds, occasionally close to 1,000, without any symptoms whatsoever and without any meaningfully elevated risk beyond what would be statistically expected for their exact age. A number like that, delivered without proper context, tends to land with the emotional weight of a diagnosis, even when it is nothing close to one. What tends to follow a frightening calcium score is, by this point in the story, a familiar and predictable pattern. Anxiety quietly rises. Physical activity, the very behavior most consistently linked to better cardiovascular health, sometimes decreases out of fear that movement might trigger a hidden problem. Patients occasionally request further imaging or interventional procedures, sometimes successfully, even in the complete absence of any blockage-related symptoms. A high calcium score in an older adult does carry a general statistical association with cardiovascular risk, and within a broader, carefully explained conversation, it can genuinely add value. But used in isolation, stripped of context about ordinary age-related calcification, it far too often produces more fear than clarity, and more downstream procedures than measurable benefit. Step back for a moment from these 4 specific screenings, and notice the pattern connecting every single one of them. In every case, the test itself is painless, quick, and genuinely low risk on its own. The real danger never lives inside the screening tool. It lives in what happens next, the chain of additional testing and procedures triggered by a finding that statistically was unlikely to ever cause harm across the rest of that person's life. Researchers studying this exact phenomenon sometimes describe it using the image of a quiet current running beneath calm-looking water. Nothing about the surface appears dangerous, and yet once you are pulled into that current, the path back to shore becomes considerably harder than the simple act of stepping in ever was. There are a handful of beliefs that quietly shape decisions in exactly this moment, and most of them turn out to be only partly true once you look closely. The belief that more testing always equals more safety overlooks how false positives behave differently depending on how likely disease actually is in the person being tested. Belief that an abnormal result always means disease ignores how much of what shows up on a scan in someone past 65 is simply the visible signature of normal aging rather than illness. The belief that if a doctor recommends a test, it must specifically benefit your individual situation overlooks the fact that many recommendations come from general protocols designed for broad populations, rather than from a careful weighing of your personal symptoms, history, and risk profile. And the belief that a free or low-cost screening carries no risk overlooks the simple truth that the financial cost of a test and the medical risk of what it sets in motion are 2 entirely separate things. It is worth pairing all of this with something far more encouraging, because the story of an aging heart is not only a story about which tests to question, it is also a story about which everyday habits genuinely move the needle on long-term cardiovascular health, often far more than any single scan ever could. Regular movement, even moderate amounts like brisk daily walking, helps maintain the flexibility of blood vessels and supports healthy blood pressure in a way that compounds meaningfully over years. Consistent, adequate sleep allows the cardiovascular system nightly periods of genuine repair, and chronic sleep deprivation has been linked in research to higher rates of high blood pressure and irregular heart rhythms over time. Chronic, unmanaged stress keeps the body's stress hormones elevated for extended periods, which over years can contribute to elevated blood pressure and low-grade inflammation inside blood vessel walls. Dietary patterns rich in vegetables, fruit, whole grains, and healthy fats, similar to what is often called a Mediterranean-style way of eating, have been associated in long-term research with meaningfully better cardiovascular outcomes than any single supplement or quick fix. And perhaps most underappreciated of all, strong social connection and a sense of purpose in daily life have been linked in multiple long-term studies to better cardiovascular outcomes in older adults, a reminder that heart health has never been purely a mechanical story about pipes and pressure. None of these habits will ever appear on an imaging report, and none of them generate a dramatic number that can frighten or reassure you in a single instant. but across years and decades, they tend to matter more than almost anything a scanner can detect in a single afternoon. So where does all of this leave a healthy, symptom-free older adult who genuinely wants to take excellent care of themselves without accidentally stepping onto one of these conveyor belts? The answer is not to avoid your doctor or to reflexively refuse every test ever offered to you. The answer is to change the nature of the conversation that happens before you agree to one. There are a small number of questions that, when asked sincerely and without confrontation, tend to reorganize an entire medical decision in a noticeably healthier direction. The first is refreshingly simple. If I feel completely fine right now, how exactly would the result of this particular test change what we actually do next? This question forces a concrete answer rather than a comfortable, vague reassurance. If the honest response is that very little would change regardless of the outcome, that tells you something genuinely important about the real value of the test for your specific situation, today at your specific age. The second question worth asking directly is what the realistic chance of a false alarm looks like for someone your age, given everything we have just walked through about how false positive rates tend to climb in low-risk, symptom-free populations. The third is simply asking what watchful waiting would actually look like as an alternative, what specific new symptoms or changes would prompt revisiting the decision, and what kind of monitoring, if any, would happen quietly in the meantime. A physician who is genuinely confident in their recommendation will almost always welcome all three of these questions without hesitation or defensiveness, because shared decision-making, where a patient is treated as an informed partner rather than a passive recipient of instructions, consistently produces calmer, better-aligned outcomes for everyone involved in the room. There is also a quieter, more personal layer to all of this worth acknowledging honestly before we close. Aging well is not the same project as eliminating every conceivable risk a scan happens to be capable of detecting. The two ideas sound similar on the surface, but they are not the same thing at all. A life spent chasing the complete elimination of every statistical shadow that modern imaging technology can locate inside an aging body often becomes, almost paradoxically, a smaller, more anxious, more restricted life than the one that comes from simply accepting that some degree of biological wear is, quite reasonably, the price of having lived this long and this fully. The goal worth protecting is not a flawless scan result. It is the version of your life where you are still walking, still gardening, still traveling, still showing up fully for the people who matter most to you, supported by medical care that genuinely earns its place in your story rather than medical care that arrives uninvited and quietly reshapes your remaining years around a number you never fully understood in the first place. None of this requires distrust of doctors or of modern medicine, both of which remain extraordinary, genuinely life-saving tools when matched correctly to the right situation. What it requires instead is a small shift in posture, from a patient who accepts every offered test as automatically beneficial by default, to a patient who asks gently and respectfully what a particular result would actually mean for a life that, by every honest account, is already going pretty well. That single shift in posture, repeated quietly across millions of appointments every year, is exactly the kind of thing that changes outcomes meaningfully at scale, even though it will never make a single headline on its own. If there is one idea worth carrying out of this video and directly into your next appointment, let it be this: feeling well is not a glitch in the data waiting patiently to be corrected. For a healthy older adult with no symptoms, feeling well is, very often, the single most meaningful piece of clinical information in the entire room, and it deserves to be weighed seriously with real respect, before any test is allowed to rewrite the story your own body has been quietly and consistently telling you all along.